Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Toney.
Hello, everyone. This is Christopher Toney again, and thanks for joining us on Straight Outta Health IT. I am so very excited today to have as my guest Bernard Toney Jr. Mr. Toney is a former White House medical officer for the White House Medical Unit. He served under two presidents, and I am so excited to talk to him today about his journey from Stone Mountain to the White House and to learn more about his passion and focus post the White House and the things he's doing now in his new role. But before I, delve into questions with Bernard, I'd like to just give you a summary of his background. As an executive medicine to the office of the president and the office of the vice president, Bernard served as the sole medical provider for the vice president and first lady of the United States for several missions. Impressive. In addition to those responsibilities of, really taking care of our nation's leaders, executive leaders, Bernard was also responsible for developing, planning, and implementing results-driven medical and medical contingency plans to support the president, vice president, first family, and second family. He also developed and implemented medical contingency plans in 22 states and 5 countries to support executive level health, security, and public health preparedness. He also provided oral communication, which delivered medical presentations to the government and non-governmental agencies and international stakeholders. He also supported the policy analysis and support, providing COVID-19 specific recommendations to internal and external stakeholders concerning screening, testing, diagnosing, by assisting and coordinating the organization's response to the COVID-19 pandemic. And he successfully provided medical supervision, guidance, and mentorship to 39 United States Secret Service personnel with specialized training in chemical, biological, and radiation mitigation. Wow, what an impressive background. And I'm so, again, excited to have you on the program, Bernard. Thanks for being here.
Thank you for having me, Chris. It's a pleasure.
So let's jump right into it. I'd like to hear from your own perspective, your journey. How did a person, an individual like yourself, a young African-American man who went to school at Redan High School in Stone Mountain, go Stone Mountain. How did you end up, from that place in your life to now, being in the White House, flying on Air Force One and taking care of the first lady and the second lady and the president and the vice president of the United States?
Well, again, Christopher, thank you for having me. It's a pleasure to be able to talk to you and your listeners. I'll tell you that I had a very unorthodox pathway into medicine writ large. At the age of 17, I grew up, my first formative years were in Decatur, Georgia. We moved to Stone Mountain when I was about 12 years old. At 17, I was a victim of a drive-by shooting in Georgia, Memorial Drive, if you know where that is.
Oh, absolutely.
And so I was leaving I guess you would call it a club or a party. And I had myself, and my 3 friends in my vehicle. And there was a drive-by shooting that occurred on Memorial Drive in March of 1999. And as a result of that, my best friend, Ivan Gray, struck in the chest, took 1 gunshot wound to the chest. And I had the responsibility of trying to get him the care that he needed. So calling 911 and trying to convey his injuries in our location to the dispatchers was very difficult as a 17-year-old kid, as you might imagine. And nonetheless, he died in my arms. And,
oh my God, I am so sorry.
No, it's okay. It's a part of my journey and I'm willing to share it. But it's one of those situations in my life that I felt very unprepared. I did not know exactly what to do. It was probably one of the worst feelings that one can ever imagine being, one of the worst situations you can ever imagine being in. And at that moment, I realized that I would never want to be in a position of the care of someone else and not know what to do.
Right.
And so that's where my passion for medicine started. Unfortunately, before that happened, I had already enlisted into the military in what's called the delayed entry program. So I enlisted into the military the previous December, and I was already committed to going into the military as a Russian linguist. And a long story short, I ended up being a French linguist at some point, working for the special forces in Fort Bragg, North Carolina.
Okay, stop there for a second. So let me be clear. So you speak Russian and French?
So we'll say Russian is a distant language in the past for me. French is where I focus most of my efforts, and that's what I did for about 3 or 4 years in the 3rd Special Forces Group at Fort Bragg, North Carolina.
Exactly.
So long and short, I still had the passion for medicine. So what I found myself doing was certainly working with special forces, the medics, and the physicians on any medical endeavor that they had while I was a French linguist. And so I did that for a while until I went back to college. I left the Army, went back to college and got my first undergraduate degree. And the rest is history. I just continued on a pathway of attaining certain medical skills in education. I'm trained as a physician assistant. I have a doctorate degree at the PA level as well. And I did that for a number of years, which ended up leading me to an opportunity to work at the White House Medical Unit. And that's what I did from the latter part of 2018 until just most recently, April 2022.
Man, what an amazing story of turning tragedy into a passion and a journey in your life, and ultimately ending up in, one of the most powerful places in the world, serving and supporting our executive leadership. First of all, thank you for your service. This podcast is actually being recorded on Memorial Day. It may not air on Memorial Day, obviously, but it is being recorded on that day. So I want to thank you for your service and your commitment to this country. Again, my condolences on the loss of your loved one. I've recently experienced not something quite as tragic as a gunshot, but my brother-in-law unfortunately contracted COVID, was on a ventilator, lungs collapsed, and we made the decision at some point to end his journey. And so we watched him take his last breath as well too. And so I can't even imagine as a 17-year-old watching my best friend who was tragically shot and holding him in my arms and also trying to convey to, care providers his situation and comfort him in that time, and ultimately to watch him lose his life. So I'm sure he's looking down from you at heaven and very proud of, the person you've become and the journey that you've taken as a result of what happened to you.
Thank you so much. And I feel the same way, the same sentiments for your loss as well. That had to be very tragic, particularly given the context. So
absolutely. And I'm sure we'll touch a little bit on the whole COVID situation later in the podcast as well too. So let's jump right into some of the questions that I have for you. Just tell me, I'm sure everyone's interested. What was life like for you being under that microscope, in the White House, and not only serving as part of the medical staff there for the president and vice president, but also having the challenges of supporting and coordinating those efforts during the COVID-19 pandemic. Talk about a time to be a part of the White House, serving under now 2 presidents and watching that journey take place.
Yeah, well, great question. I'll tell you that when you say under the microscope, I'll say that we really didn't live under a microscope at all. Part of the White House Medical Unit, as you might imagine, is to be there and prepared for contingencies to ensure the continuity of the office of the president. And so in many ways, our mantra was to be silent professionals. We were rarely ever seen. And if we were seen, it was by sheer accident. So our mantra was really to be off camera. Most of what we did was in the background. And so I think that COVID-19 sort of brought us to the forefront because it was a significant life-altering event for the entire world as a pandemic. But for the most part, our posture and our position and the way we're designed is to work behind the scenes and to never really to be noticed, and let the leaders lead, and we support in the background. I can tell you that COVID-19 was a significant challenge for us, just like many other institutions. We had to dramatically pivot in the way that we conducted business, in the way that we traveled, in the way that we interacted with people. And protective medicine, which is what we did, took on a whole new definition. in that we were more so looking for the invisible enemy as opposed to what many might consider the visible enemy that we tend to train for in a trauma perspective. And so our mitigation efforts were extremely difficult. As you might imagine, many communities had to have their own mitigation efforts for their community, but we were a traveling bubble around the entire world.
Right.
And so managing COVID mitigation strategies while traveling from the United States across the entire country and then overseas took on a whole new challenge that took a whole of government approach. Luckily, we had the benefit of having partnerships with the CDC and epidemiologists, Department of Health and Human Services, and others to be able to perform these functions. But we were able to do it. I think we have a great team. We still have a great team, and I think the unit has always been an organization of professionals that are able to dig deep into their bona fides of medicine, but quickly pivot in the face of adversity.
Yeah, I can imagine the myriad of challenges logistically you and your team had, and protecting the president, vice president, and their families as they traveled amongst folks here in the U.S. and across the globe. Obviously, there were folks who did fall victim to the virus, and now trying to mitigate the risk associated with that as well. And, again, dealing with all those myriad of logistical challenges and trying to keep the first family and the second family safe. So, again, kudos to you and your team for managing that successfully. You're welcome. So, given that whole experience that you went through, in the White House, serving under these two presidents, and two presidents, if you wouldn't mind sharing that as well, which ones you have served under. What are some of the life lessons, you gained from that experience?
Sure. So I've served in the last 3 years in the White House, so that will cover President Donald Trump and President Joseph Biden. And so I would say that I've already gone through life living in multiple states and 3 different countries around the world after having been in the military for 20 years. But I would say that the White House was the most diverse group of individuals that I've ever worked with. And I say that not just in diversity with respect to race and ethnicity, but also diversity of thought.
Right.
And so I would say that it didn't teach me a lesson, but it reinforced the idea that our diversity is what strengthens us in most situations. So I was able to lean on people who didn't look like me, people from different ages and backgrounds throughout my entire tour there in a way that I've never had to in the past.
Exactly.
Particularly because we were serving in the White House during significant racial issues within in the United States.
Mm-hmm.
We had a lot of as you well remember and know, a lot of racial tension in the United States, and serving in a diverse unit in that way gave me actually more comfort to know that we are a microcosm of society, and that one I would like to transplant, to the rest of society, so that all of the United States and the globe, quite frankly, can function in that way with that level of diversity. I would also say that despite what the pundits on the media report, that the White House is always in some sort of disarray, depending on which administration is in office, I will tell you that for the most part, everyone in the White House is a mother, father, brother, sister, they're a child of someone, and they all want to make our country better than the way that they inherited it. And so that is the sentiment that I got when I was working at the White House. And a lot of times that isn't conveyed in the media, and I wish that it would be so. But unfortunately, a lot of people have their own agenda. Sometimes it's a political agenda. But the White House is a very well-functioning place, very diverse institution and organization, and it's been that way across 2 different presidents that I've served under. So again, that diversity of thought and background was a strength for us, not a weakness.
Well, that's good to hear because, as someone on the outside looking in and obviously listening to, what we hear on media and social media about what's happening in the White House and with our leaders, you wonder, is it, a circus that's happening there on a day-to-day basis? And if people got their stuff together, and then in some cases, wonder, is there diversity of thought and diversity of individuals who are putting these very critical roles to serve our communities, and lead our nation. And so it's comforting to some degree to hear you share that there was diversity in 2 very different administrations, And that people are human as well, too. I mean,
Right.
these folks aren't machines, that they have families, they have, concerns, just like every one of us that get up every day and go to work. And hopefully they're going there to try to do the best job possible,
Absolutely.
despite their political affiliation. So I'm glad to hear your perspective on that as well. That being said, obviously you are, you've done your tour of duty, both
Right.
in the military and in the White House, and now you've pivoted to a new role at the National Institutes of Health, which it's, I'm sure, very interesting and exciting as well, too. So why don't you share a little bit with the listeners what you're currently up to today?
Right. So I've joined the NIH, or the National Institutes of Health, and in particular, I've joined a team within the NIH that focuses on vascular medicine and thromboinflammation. It's truly, if you can ever imagine, an institution that has dual missions. And so one mission is research and another mission is clinical medicine. And that's where the NIH intersects. And so we focus on a translational approach within my team towards discovering novel prevention methods, diagnostic methods, and treatment strategies for patients that have any wide array of vascular issues and thrombal inflammation, which is our singular focus on my team.
That sounds really exciting. And I know you're just recently starting there, at NIH. Are there any specific projects that, you're now kind of deeply immersed in right now that you can share, or are you just kind of still getting your feet wet?
A little bit of both. So still getting my feet wet. But the other thing is that, it's not like a classified sort of scenario, but when we're talking about clinical trials, there's a certain level of discretion that we have to have with respect to those clinical trials until they're open for publication and things like that. So a little bit of both with respect to your question.
Absolutely. I understand. I won't press you any further on that. But I do want to kind of pivot again to some conversations we were having as we were prepping for this episode of the podcast. You shared with me, really your passion for addressing health disparities in our country and around the world, and really closing the gap in health disparities in, underserved communities. And I believe you'll probably continue to focus on some of that in your role in NIH, but also wanted to get your thoughts and perspective on this as well. And I too believe that the quality of care shouldn't be based on, a patient's socioeconomic, ethnic, or gender or geographic background. Unfortunately, our healthcare system tends to fall short when we talk about these very vulnerable populations because of social determinants of health, whether it's a lack of insurance or low income, or quite honestly, biases amongst, ethnic minorities, or racial, or, sexual orientation, et cetera. So, how do we get past this? How do we embrace diversity? You mentioned that one of the greatest experiences you had in the White House was the fact that you worked with a very diverse group of, healthcare professionals and leaders, and that helped you guys make better decisions. To help me understand from your perspective, your insights around that, what's the root cause of these issues in our country and across the world, and what can our political officials and our business leaders do to start to close the gap around what I call social determinants of health, or what others call social determinants of health, but what I also call political determinants of health, the policies and initiatives that really also help to shape how we deliver care in this country.
Yeah, no, I appreciate the question. And I haven't heard political determinants of health until today, but I would say that, again, these are my opinions and my thoughts, not representative of the White House or the NIH. But I would say that, the functioning of a well, tailored democracy is that you have to have inclusive political and economic institutions. And I'm glad that you sort of separated those two, both political and, you said, business leaders as well, because the fact remains is that, if you don't have inclusivity in your political and economic institutions, then ultimately you're not exercising a large portion of the population that can otherwise be, maximizing their potential to the growth and development of this country. And you can make the same argument around the world. But it's not just the institutions themselves, it's the policies that come from those institutions. And I think that's That's what's very important. COVID-19 put this in perspective for us. There was a study that was published in, I believe, November 2021 from the Journal of the American Medical Association. And they looked at about 219 million people. And they basically concluded that if all people within the United States had the same level of access and resources as the socioeconomically privileged, that being college educated, non-Hispanic white individuals, that the number of COVID-19 deaths in the United States would have been halved. It would have been 50% less.
That's amazing.
So what drives that? It's where we live. Do we live in unsafe neighborhoods? Do we live in overcrowded environments and ghettos? I'm using air quotes here, but the hood is where do we work? Do we have the means to telework? I have a lot of colleagues, in my industry, within my cohort that can telework and they can continue to work, from home.
Right.
Many people who live in socioeconomic disadvantaged populations cannot. They physically have to show up to their jobs. Where we study, do we get access to the same quality education that some others in privileged classes do? And do we receive the same quality of healthcare or not? Many people, as you mentioned, are uninsured in the United States. So all these different determinants are what led to significant health disparities as a result of the structural inequalities within the United States. So until we start driving policy that can address that from both a political and an economic perspective, we'll continue to have the same level of disparity, if not worse, on the heels of COVID-19 that we've always had.
No, that's a good insight. You talked about that from a political standpoint, and I mentioned also, kind of business leaders. And it's clear to me that healthcare organizations must ensure that their staffs are educated on disparities to appropriately address the needs of patients from diverse backgrounds and cultural and economic environments in order to be able to provide equitable, high quality care. It's been shown that patient-centered care improves clinical outcomes and patient satisfaction while reducing medical errors and costs. Can you offer any practical advice on how leaders can begin to close that gap and holding their staffs more accountable in this area?
Absolutely. I think what we need to do is, obviously we can focus on post-service, in-service training at the institutional level for our staffs and our healthcare professionals. But I think what's most paramount is that we focus on pre-service education in the nursing schools and the medical schools and the PA schools, where we can focus on how medicine intersects with these social determinants. It is very unfortunate if someone goes through all of their pre-service education, that being medical school, residency, et cetera, and the first time they meet poor, disenfranchised populations is on the other side of that.
Right.
And so they don't understand, how their communities impact their health, or their upbringing, or their health literacy might be impacting their health, or literacy in general. And so I think if we can focus on the pre-service education by including diversity, equity, and inclusion within the curriculums, then I think we will allow for more diffusion as people go out into to their respective areas within the country and practice medicine.
And that's an interesting perspective. So you're suggesting then, as a part of your medical training, then medical students should go into these urban or underserved areas and practice medicine, or
just the curriculum.
I'm sorry,
correct.
Go ahead.
The curriculum should, if they don't have proximity to it, it may not always be feasible.
Sure.
But definitely from an academic perspective, it should be introduced. I'll give you a great example. When I was in school, I was told that Black patients are more susceptible to hypertension, diabetes, and et cetera, all the chronic disease.
Right.
Well, the TYR gene that provides the enzyme called tyrosine, which is what's responsible for the production of melanin in our skin, does not predetermine or predestine me to chronic disease. It's purely a phenotypic or a visual expression of color. It has nothing to do with our susceptibility to chronic disease.
Right.
That's what I was taught.
Right. So because I'm Black, that I'm not predestined to have hypertension or diabetes or some of these
Exactly.
other diseases. And I think to your point, we are conditioned as a society to think that, oh, well, my mom was on high blood pressure medicine, my dad was diabetic, so I'm just predestined that. And a lot of it has to do with our socioeconomic and social determinants, the diet and exercise and education and access to healthcare and all of that really predetermines that as well.
Absolutely.
No, that's interesting. Thanks for sharing. I wanted to just quickly, I know we're running short on time here, but I wanted to go back to the COVID pandemic. And, as we're starting to hopefully come out of this in terms of, the critical nature of it, and we're starting to make this as a part of our new norm. What are some of the significant changes you've seen in the delivery of healthcare that's occurred as a result of the pandemic, and what are some of your predictions around how healthcare will be delivered, in the next 3 to 5 years?
I will tell you that the private sector and the public sector is acutely aware of the challenges that we've had. I'm a member of the American College of Healthcare Executives, and many of the CEOs of most hospital systems recognized that they didn't have penetrance for COVID-19 relief, vaccines, tests, and some of the most marginalized populations. We are working, I think, as Americans in both sectors, private and public, to mitigate many of those challenges, to remove those structural barriers and inequities, and create buffers and supports so that we do create more equity within our healthcare system. It's going to take time, but I think we're on the road to accomplishing that.
No, that's great. And then how do you see healthcare being delivered today differently than it might have been just 2 years ago? For example, telemedicine, it's obviously gained a tremendous amount of adoption, in the delivery model for healthcare. And do you see that continuing to be a prevalent thing, or are we going to go back to the way we used to be in terms of just going and visiting our doctors and our primary care physicians in their offices, or just in general? What's your kind of your perspective on the future of how care will be delivered?
I think that we are recognizing that in order to do what you just said, we need to invest in development writ large. There's many parts of the country that do not have broadband, internet access, or have the means to have the devices to be able to, to leverage that technology. So I think as a whole, we're realizing that it's not just healthcare that we have to focus on, or even healthcare IT, but from a cross sectoral approach, looking at development writ large. All of those elements of development, access to broadband, ensuring that we have public transportation that can meet those demands of getting to healthcare facilities when needed. We're looking at all different elements to be able to leverage, what we now have learned on the heels of COVID-19.
No, that's great. I think hopefully, history will show how healthcare significantly pivoted in the way of adopting technology, in the way that we deliver care. Now this focus around social determinants of health and diversity, equity, and inclusion will be the catalyst for that. So I'm excited as well to see what will emerge going forward. So I've got about 2 minutes now left, and I can't believe the time has flown so quickly. Just any final thought you might have, and then I've got like a lightning round of questions. So you got a 30-second kind of final commentary, and then I'm going to hit you with a couple of quick questions.
Perfect. So in 30 seconds, I would say, after growing up in a predominantly African-American neighborhood and community, after living 20 years around the world and traveling to about 26 countries now in every state in the United States, I would say take time for your listeners. Take time to talk to people who have a difference of opinion, that may look different from you, that have a different background, that speak different languages, because of all the experiences that I've had, many of them have been extremely phenomenal and rare. My most enriching experiences have been by interfacing with people who are not like me. And the more that you can do that, the better off you'll be, I think.
Great advice. So I'm going to ask 2 questions because we got literally 1 minute. Your favorite show growing up as a kid?
Home Improvement with Tim Allen.
Oh, wow. Interesting. Your favorite hobby or pastime?
Traveling. I've traveled most of North America, Europe, and Asia.
That sounds good. And then one final question. Bourbon, scotch, brandy, vodka, tequila, or something else?
None. If I drink a glass of wine occasionally.
Oh, there you go. Nice. Well, Bernard, thank you so much, man, for taking time out of your Memorial Day to chat with me about this most important topic. I wish you much success in your journey in life, and thank you for your service as well.
Thank you so much, Crystal.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Toney on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.